Well, good afternoon, everybody. I can see several people have joined the webinar already. I'll introduce myself. I'm David Wilson. I'm the Vice President of the VIR, and I'm responsible for education, so it's quite appropriate I should be one of the earlier people to take part in these processes. What I'm going to do is talk to you for the next 20 minutes or so about the new technology of fusion imaging. I'm a musculoskeletal radiologist, so I'm going to talk about extremity CT and low dose CT, but also MR and how that can be fused with ultrasound images to useful effect. And I'll show you some cases to try and demonstrate that. Finally, we'll talk about fusion imaging with reference to guided needle injections and how we might use it in that way. Then we'll throw the field open and people can start to ask questions. If you have anything to inquire, start to ask whilst we're online, and I'll see your messages coming up on the screen. So if it's pertinent to what we're talking about, I'll deal with it there and then. Otherwise, we'll talk about it after the webinar, after the main presentation takes place. I'm an MSK radiologist. I specialize in imaging of bones and joints. I'm fortunate that I now have an honorary contract with the university hospitals, which means I don't have to do full NHS lists. So I'm able to do research work and development work, and we're using some machinery which we've purchased at St. Luke's. St. Luke's is an outsourced radiology service, and we've got some new equipment that we're able to do some development work with, and I'm going to share the results of that with you. The topics I'm going to cover are first, very briefly, extremity CT, because I think you need to understand this to see what we're doing with it. I'm going to paint that in the context of fusion imaging, and then show you some examples of MR fusion and CT fusion. And finally, as I said, fusion guidance. Low-dose extremity CT is new. It's used as cone beam technology, which is a little different to conventional CT, and the huge difference that results from this in practical terms is that it's only 10% of the radiation dose of conventional CT. So here we have a patient being examined looking at the wrist. We're acquiring a volume acquisition, which is in effect about 640 slices. It's an isotropic volume, which means that the volume is the same resolution in all directions, approximately 0.2 millimeter per pixel. This means the CT we acquire, say a wrist, an elbow, an ankle, a knee, will be higher resolution than conventional CT, especially in the off-axis planes, and a lot of data. Indeed, that's so much data that it can be a bit of a problem if your machine that you're viewing it on doesn't have enough RAM. We recommend about 8 gigabytes of RAM to deal with the images because it's a lot of information. It takes 18 seconds to acquire, and we produce sections which are reviewed as a MIP, and they look like this. Here's an example of an ankle sprain patient. We're currently doing a research project looking at acute sprains to see if there are occult fractures. We're looking in 2 planes here, but this would be a multiplanar reconstruction which we can rotate, and you can see that we found an anterior process fracture, which if I zoom down on that, you'll see in a bit more detail, was quite occult on the X-ray. We couldn't see it. We reviewed the X-ray, couldn't see that. Here's another example of a patient with an ankle sprain sent home from the accident emergency department. We asked patients to volunteer to see if they'd take part in the study. To date, we've examined 72 people this way. When we reach the 100, we'll start to publish. Here is a talar fracture. You can see on the bottom part of the fracture, which is here on the coronal reconstruction, and on the medial side of the talus, there's a talar fracture. Again, something that we couldn't see on the conventional radiographs, even in retrospect. So how do we use this data with fusion? Well, these fractures will be visible on ultrasound to an extent. This is the fusion setup, and the examples on the right this time are MR of the spine, but Gina, my wife, who's a radiologist as well, is performing a fusion imaging on an ankle. You can see that by the side of the patient there's an extra bit of kit. This device is a magnet. It's a little magnet with a small field. It has a warning pacemaker sign on it, but we suspect the magnetic field isn't strong enough to affect any pacemaker. But I think we wouldn't scan a patient with a pacemaker this way, just for the time being until we're absolutely sure. This is connected by a wire to the ultrasound machine. The ultrasound machine has 2 additional wires connecting to the probe. These are, in a sense, GPS sensors. They detect where the probe is in the space by using the magnetic field that's generated around the area to detect it. If you look at the images on the right, we've imported an MR into the ultrasound machine. It takes around about a minute to import the slices. We then fuse them with the ultrasound image. So that's the ultrasound image representing the area inside the green box. If we rotate the probe through any direction, but here 90 degrees, we can now see the ultrasound of the facet joints in a sagittal plane. Of course, the shadow cast means we see nothing behind them, but we see exactly the same image on the MR in the sagittal plane. Here's the facet joint, that's creating the bump on the ultrasound, but because we can see the bones behind, we can see the disc spaces. Now this is in real time. You can rotate them as you wish, you can move it in any direction, and it moves as fast as the ultrasound does. That means we can see the soft tissues, we can look at Doppler, look at the neovascularity. At the same time, we can see the MR rotating in the same direction. So how do we link these images together? Well, that takes probably about 5 minutes. At first, it took me at least quarter of an hour, and there's some pitfalls and tricks involved in it. And anybody starting this, I advise you to work with someone who's done it before to learn the vagaries of the machinery you're using. Several of the big manufacturers produce the equipment. We happen to be using General Electric, but I know Hitachi and Toshiba, very good systems as well. And I believe some of the others are coming online very shortly. So we fuse the images. Well, what we do is we take a reference plane, and it would, in the case of a spine, would be very sensible to look at an axial plane, but an ankle I find the sagittal view is quite good. And we then line up the MR images or the CT images in the same direction. And we can use the ultrasound machine controls to rotate the volume data set till we do. Once we're sure our plane is correct, we lock the planes and then find a reference point on those images that we can see both on the CT and the ultrasound, or the MR and the ultrasound, and mark that on the two planes. Then I like to check several other points to make sure fusion is sound. Sometimes it isn't, so we need to restart, or sometimes simply just get another fusion point and click on those points. It takes now for me about 5 minutes to do that, and it's the long bit of the procedure because you've got to get everything lined up. Once you've done that, it's straightforward. As you move the ultrasound probe, the CT or the ultrasound, and the ultrasound move in coincidence. Here's an example of an ankle. We're looking here on a coronal MR of the ankle on the right-hand side. The little green box contains the area that's shown on the ultrasound. Notice how much better the soft tissue resolution of ultrasound is, and obviously how much better the MR is for the joints that we can't see on the ultrasound. One use of this is simply educating yourself as to how the anatomy of the ultrasound relates to the underlying structures, because I don't think I'd really realize that the two joint surfaces, this is the tibio-fibular joint here, and here the tibio-talar joint, how they run away at different directions, just looking at the ultrasound. Of course, it becomes obvious using the MR. If we look at another example here, this little sesamoid bone is actually the pisiform of the wrist. We're looking on an MR, very zoomed down, and we're looking on the ultrasound, and we can see here the muscle, subcutaneous fat. We can see exactly the same structures on the MR, because the MR shows us the joint surface underneath and the articular surfaces. If we look at CT, this is an extremity CT, volume acquisition. We're looking here at the ligaments and tendons, very well seen on the ultrasound, not so well seen on the CT. Here's the ulnar styloid, because we can't see underneath it with ultrasound, but we can see with the CT, we can demonstrate the joints and the spaces between the bones. This, to me, is teaching me a great deal about the anatomy and what I'm looking at on the ultrasound study. This, the triangular soft tissue structure we're looking between the bones, and here, outlined by the arrow, is the triangular cartilage, and we know where that should sit on the CT examination. Now move on to an ankle. This is using CT on this occasion. The anterior aspect of the ankle, again the green box containing the ultrasound. We see the soft tissues of the tibialis anterior. We can see the dorsalis pedis artery running down here. You can switch the Doppler on whilst you're doing this to look at it if you wish. The articular surface of the talus is seen as a black line, and this fat pad, triangular fat pad sitting inside the joint. The ultrasound proves to us there is no joint effusion. It allows us to look at neovascularity, but we can see the depth of the joint and the osseous structures. In the case of, say, ankle trauma, as we were looking at earlier, we can see the fractures using the CT examination. Here's a little further down on the same patient's ankle. We're looking at the navicular. This is the dorsal aspect, the little osteophyte spurs. And we can also see the joints underlying it. Here's an example of how we could use fusion. This is just one where I learnt more about the patient by using a combination of the techniques. We looked first of all at this patient who'd had a fracture. This was a squash injury, bad fracture. He'd had an implant. Screws and plates were put in to deal with the fibular fracture. This united, and by this stage everything had united and all would appear to be well, but the patient had pain on standing, and this is about 7 months after the injury. Our first thought was, does this patient have a septic implant? So, as is our routine, we look with ultrasound to look for abscess cavities, we're looking for neovascularity around the plate, we're looking for tendon impingement, we're also looking for periosteal reaction and elevation. None of those were present. We could see on the ultrasound at the side of the plate, with the screws, the plate, no reactions in bone, and all looked well, and none of the biochemical and hematological markers suggested there was any infection, so that was a great relief. But why has he got pain? Well, one of the advantages of the extremity scanner is that we can stand people up, and we can scan them in a standing position. So here we have the coronal reconstruction of the ankle when the patient's supine. And remember, the radiation dose is so low, it's about the same as a conventional radiograph. It's quite reasonable to repeat this. It's just like taking a second view of the ankle, an AP and lateral, for example. So here is the standing view. And some of you astute viewers will have noticed that there is a narrowing of the joint space that we didn't realize. It's a young patient, and he'd got articular surface damage we didn't realize, which suddenly became apparent when you put weight on it. So that's a potential cause of pain which we didn't recognize. But we noticed something else at the same time using this, and that was that when he stood up, the fibula moved away from the tibia. Now it shouldn't. It should be tied down by the anterior tibiofibula and the posterior tibiofibula ligaments. So clearly there's a problem. Let's have a look at what it looks like when we compare it with the ultrasound. So doing this with fusion imaging, here the two images fused together, we can see the ultrasound on the left-hand side. We can see the anterior tibiofibular ligament as a discrete structure. It's there. There's a little chip of bone that may have been an avulsion fracture at the time. We can see that close in and also identified on the ultrasound. But when we move the patient, ask the patient to move his ankle up and down, then things changed. So this is with the foot dorsiflexed, and those of you that know the mechanics will realize that actually puts pressure on the tibia and fibula and pushes them apart. And here we can see on the CT, that's a previous image, clearly, we hadn't all taken at the time, so it's exactly the same alignment, but the fibula has now moved anteriorly on the ultrasound. So by looking at the two and comparing the two, we can see that everything's changed. The fibula has moved forwards, which it shouldn't if those ligaments are intact. So there's clearly here ligamentous diastasis. If we take another case, and I should have said that last patient benefited because we told the surgeons, they went back, they explored under anaesthetic, agreed with us there was diastasis, and put diastasis screws and repaired the ligaments, and there was considerable improvement. Here's another example of how comparing the imaging, fusing them sometimes, bringing them together and looking at them side by side gives you more information. This patient has had a skiing injury. She was operated on in France in the Swiss Alps, and very effectively they rebuilt the proximal tibia. The extremity CT showed she'd actually got a tibial spine fracture, which hadn't been recognized at the time. This appeared to be healing up, and it certainly wasn't where the pain was. What was perhaps unusual about this case was it wasn't really the fractures that we can see in detail on the axial section here that seemed to be causing the problem. What was happening was that I'll go back, because down by the plate, and I'll put a little arrow on it and show you, this was where the pain was. She was pointing to this area, and can you see this little kink in the bone? That's all that was apparent on the CT. I don't think we'd have thought very much because there's kinks all over the place. But when we had a look on the ultrasound in that location, we could see that there was a little step in the bone, and we could see the medial collateral ligament was a bit edematous higher up. And if we go on and switch the power Doppler on, all of a sudden, huge amounts of neovascularity in the medial collateral ligament, just where that spike of bone was impinging upon it. So the two images together told us that this was medial collateral ligament impingement due to the spur of bone. Here's another example of a patient where we're looking at the ankle, pain, and we're looking here at the side of the talus and the calcaneus. This is its anterior process. This is the subtalar region, and this is where the cruciate ligaments join the two structures together. Look at the neovascularity in this area. Now, the CT told us where we were looking. You can see here is the joint space, and on this is the beginning of the joint, but look at the neovascularity. So this is a patient who had a sinus tarsi problem. We've got edema, swelling, and almost certainly a soft tissue injury in that location. I'm going to go on to the spine and talk about sacroiliac joint injections. Those of you who've tried these will realize these are very difficult, and we're coming on to how fusion imaging can help us with needle guidance. Many people will use CT guidance to get into this complex structure. Others will use fluoroscopic guidance. The reason why it's difficult is the anatomy. If we look at the joint separated, you can see there's a fibrocartilaginous area at the front of the iliac side, and then hyaline cartilage on the opposite side over a large area on the sacral side. So if you try and put a needle in the top where there are just ligamentous attachments, nothing's going to happen. You have to get into this area. This is where the joint is. And you've got to come in from behind, so it has to be in the low area. That's one reason why people have difficulty getting into this joint. The other reason are these structures. Both anteriorly and posteriorly, particularly posterior, there's a large ligamentous complex. These ligaments are named by the two bones they're joined, so this is the sacroiliac, this is the sacrotuberous structure. If you then add another layer, you can see there are posterior, more superficial, another layer of sacroiliac ligaments. It's very thick. It's about 1.5 centimeters to 2 centimeters thick. Often people place their needles in this region and don't realize they haven't reached the joint. If we have a patient with pain, which may be arising from the sacroiliac region, these are the clinical signs that are used. You can palpate it, see if there's pain, compress it by pushing on the leg or standing, distract it by pulling on the leg. You can thrust, in other words, push the knee when the patient's leg is slightly flexed, see if that hurts, and of course get them to stand on one leg. Sadly, these tests have only between 10 at worst and 60 at best % correlation with positive response to provocative injections. So in reality, they're often less than 50%, and a toss of a coin would be as useful. And people who are in the clinical field realize that the clinical signs are poor and there isn't any one consistently valuable test. So a lot of us are asked to block the SI joints just to see if that's part of the pain. How do we get into it? Well, this is tricky because if you look at the axial sections on MR here, here's the joint. Remember I said that the inferior part is the bit that reaches the surface, so we can see that near the surface here in that area. But as you go further up, not only did the joint become more oblique, it becomes deeper, and part of the ischium line's in the way. Some of the ilium comes around the back there. And it's of different shape and different locations, so you can't guarantee that one needle inclination will work if you are doing it with fluoroscopic guidance. A lot of us have used fluoroscopy, and this is how it should work. We're placing the needle from the posterior aspect, first of all a marker to tell us where we are, that's a pointer, then the needle placed into the joint, then the contrast agent injected, and we can fill the joint. Remember, it will be the inferior part of the joint that fills, more anterior it will go a little bit more superior. That's how it should work. But the reality is that most of our injections look like these. These are all separate cases. Extravasation into soft tissues, running into the gluteal muscles, extravasation outside the joint, extravasation close to the joint, not in it, we see the joint without contrast, and a similar case. These were consecutive patients done by a team of people who are experienced MSK specialists. It is easy to miss the joint. So how can we be more accurate? Well, many people will suggest CT. Big problems with this are, here's the needle coming in, going to the back of the joint. You've only got an axial plane. It's really difficult to tilt this anymore. Tilting the gantry is pretty well impractical in this area because the patient's filling most of the gap. And you can only get a small amount of tilt. So if you want to run uphill, which you usually do to get into the joint, it can be tricky. Also, there's a lot of radiation dose, both to the patient and the operator. Sync negative, in my view. People have tried ultrasound, and there's some papers like this one by Andrea Klauser and her colleagues, which have said that it's modestly good, and probably as good as fluoroscopy, and maybe not quite as good as CT. But what if you fuse the images? We've got the ultrasound image here, and we've got a fused image here. I think things change, because now we can see the joint on the CT, and we can see where it should be. The yellow lines are outlining it on the ultrasound. We have a much clearer idea. Problem is, your needle's pretty well likely to come in at 45 degrees at best to the angle of the beam, and so it's very hard to see the needle tip. Well, there is a way around that. Here we've got a patient who we wanted to lesion the SI joint. We wanted to treat the patient who'd got pain in the sacroiliac joints by putting needles next to the S1 roots and below. Oh, I'm sorry, this hasn't come up. It's meant to be a video and it's not projecting, so I'll go on to the next case. Here's a patient where I wanted to do a root block. Just the same as doing an SI joint injection, the same technique is used. What we did was we fused the images with MR. This is the ultrasound, this is the MR in a sagittal plane. You can rotate it into an axial plane. Notice that these were sagittally acquired images with 5mm thickness, so the axial image is very fuzzy. The next case I'll show you, it's rather better. We can see here that I've identified a point which is near to the nerve root, and I do the same with the SI joints. And we can see that the target point, little green marker, has been placed. If you look at the top right image, I'll show you with the little green pointer. Here's the target point. Here's the target point here. It's the same structure. It's next to the L5 nerve root. I was doing an SI joint and place it over the SI joint. When we rotate the probe, that targeting point stays in exactly the same anatomical location. So it's out where the nerve root is exiting on the axial. And of course, the ultrasound, although we can't tell that, we're happy with the fusion. We're sure it's in this location. The next clever trick is that the needle has a radio transmitter in its core. There's a wire that runs down the center. So now the needle track is projected over the patient, and the little N marker here is the transmitted needle position. The green line running forwards is where the needle is going to go. You can see a little bit later on, the needle pointers move further forward, and we can get it down to the point where the nerve root is. Here's one I literally did last week. We go on to the next case. See, here are this time we'd acquired a 3D volume acquisition for the MR, so the images are much better and you can demonstrate better. Notice the top left picture. Here's the target point here with the T. Here is where the needle tip is coming through the soft tissues. Here is the nerve root emerging from the exit frame, and we've obliqued everything so we can see it in detail. And we're tracking the needle down. We're predicting with this line where it's going to go. You can see the movement artifact in real time on the ultrasound, but actually it's the guidance system that tells you more about it. By rotating the probe to a different angle, which you can do at any stage during the procedure, you have the needle in one hand, the probe in the other, we can now see that the needle tip has come down to the N, about 1 millimeter away from the nerve root here, and that's our target point just on the nerve root. Because this area is exactly the same thing on the ultrasound, we don't see it clearly because it's really hard to see it using ultrasound. That way we can place the needle within about 1 millimeter of the structure we want. This whole procedure takes approximately 5 minutes to fuse the images together and probably about 30 seconds to place the needle. It's very quick and very easy. When you do it, it feels like cheating. It is the first time in my career that I've placed a needle into the sacroiliac joint was when I used fusion imaging without hitting bone. I didn't hit bone at all, just went straight in one pass. I was really quite surprised. Never done that before. To me, this is the technique of choice for careful, complex needle guidance in structures all over the body. Other people are using it for the liver, they're using it to target breast lesions. Problems you have there is that the structures are squashy, they move around, so you have to be very careful with your fusion imaging to make sure that you are scanning with ultrasound in the same position as you are with the MR or CT you used before. We're lucky in the spine, things don't move very much. Similarly in joints, and so this is particularly useful for MSK needle guidance. So what about the accuracy of injection? Well, we know that if we do a blind injection, this is just a clinical landmarks in the SI joints, and I'm using that as my example, we have about a 12 to 22% accuracy. Ultrasound has a 40% accuracy of placement. It's a bit better, but it's certainly not good. We think CT, for which there are no papers at the moment, is probably in the 80-90% range. And my own view of fusion is that it's got to be higher than that. I find it really easy to get into sacroiliac joints, and I now find it very easy to accurately place needles right next to lumbar nerve roots. So what have we learned from all of this? Well, I think images are becoming more sophisticated. Many of us for many years have been using two types of imaging to make diagnoses and come to conclusions. But now we can link the two together. We can fuse them and we can look them side by side. And that does give you information that you really didn't have before. Teaches you better anatomy, gives you understanding of the ultrasound you're doing, but in particular, it starts to allow you to place needles and to position without using any radiation. So ultrasound and MR, no radiation involved whatsoever to me. Extremity CT, small dose to the patient, none to me. I can see huge advantages. So that's all I wanted to talk to you about, and we'll throw the field open for questions. I can see them coming up on the screen if you'd like to let me know. Okay, Graham's asking, do I see fusion imaging taking over from other methods? Yes, well, it has for me. I don't use fluoroscopy now to do lumbar root blocks. I don't use fluoroscopy to do facet joint injections. Both of them done using fusion imaging. Faster, quicker. Almost everybody who referred to me for an injection in those spinal regions has already had an MR. So it's very easy to do. I wouldn't want anybody to inject my sacroiliac joint without fusion imaging. Subtalar joints, suddenly it becomes an easy injection. It's hard, and you hit things like the peroneal tendons or the vessels and nerves. With fusion imaging, terribly easy to get in there. Clearly, we don't need it to inject a simple joint like the knee. But what about the hip? We can inject the hip without any radiation to any of us. So I think it's already taken over in my practice. I've got another question here come up. It says, how long does it take to learn? This, I think, is the problem. A lot of hospitals have already got fusion systems that have been, I know of about a dozen places already have these in place. The MRs have been taken, the CTs have been taken, so why aren't people doing this more often? Why haven't they started doing it, and why are there no publications to date? I think it's because it takes time to learn. It took me about 6 months of playing around, fiddling with the technique to realize how the buttons worked. Now I'm familiar, suddenly it's just like using an X-ray machine or using an ultrasound probe. It isn't really any different. So there's a learning curve in getting the fusion set up and getting the images linked together. It does certainly take longer than a conventional ultrasound examination. You're going to add about another 5 to 10 minutes, and with the pressures of the NHS, maybe you won't want to spend that time. But if you've got that time and you've got the luxury of it, or you've got some complicated procedure that you want to do, then I think it will pay off for both you and the patient. Anything else that anybody would like to know? Don't see anything up. Okay, well, I think that's it. If there are any more questions, feel free to email me via the BIR. We've got some email addresses. Just send it to general address, but you can send it to david.wilson@bir.org.uk if you wish, and I'll try and answer.